Welcome back to AudioBoards. Today we're covering one of the most important conditions in internal medicine, community-acquired pneumonia, or CAP. CAP remains one of the leading infectious causes of hospitalization and death worldwide. Yet despite seeing it every day, clinicians frequently struggle with three questions. Is this really pneumonia? Does this patient need admission? What's the right antibiotic regimen? By the end of this episode, you'll have a practical framework for evaluating, risk stratifying, and treating CAP from the clinic to the ICU. We'll focus on the latest evidence and guideline-based management.
Let's start with the basics. What qualifies as community-acquired pneumonia?
CAP is an acute infection of the lung parenchyma acquired outside the hospital. To diagnose CAP, you need two things. First, a clinically compatible syndrome, cough, fever or chills, dyspnea, pleuritic chest pain, sputum production, fatigue. And second, evidence of a new infiltrate on chest imaging. Symptoms alone are not enough. A patient with cough and fever but no infiltrate may have bronchitis, influenza, or another respiratory infection rather than pneumonia.
Who gets CAP?
Risk factors include age over 65, smoking, COPD, asthma, heart failure, diabetes, chronic kidney disease, chronic liver disease, alcohol use disorder, immunocompromised states. The incidence and mortality increase substantially with age and comorbid illness.
What organisms should we think about?
The classic board answer remains the most important one. Typical bacteria. Streptococcus pneumonia, most common bacterial cause. Haemophilus influenzae. Moraxella catarrhalis, a typical bacteria. Mycoplasma pneumonia. Chlamydia pneumonia, Legionella species. Viruses. Influenza, SARS-CoV-2, RSV, and other respiratory viruses. Less commonly, but critically important, drug-resistant organisms. MRSA. Pseudomonas aeruginosa. These should not be covered routinely. Coverage is reserved for patients with validated risk factors. Patients often present with fever, productive cough, dyspnea, tachypnea, hypoxemia. On exam you may find crackles, bronchial breath sounds, increased tactile fremitus, egophony. Older adults may be different. Instead of fever and cough, they may present with confusion, weakness, falls, functional decline. Always keep pneumonia on the differential in elderly patients with unexplained delirium. When CAP is suspected, obtain basic workup, vital signs, pulse oximetry, CBC, BMP or CMP, chest imaging. Chest radiography remains the standard initial imaging test. Lung ultrasound can be very useful when expertise is available. CT scanning is generally reserved for uncertain diagnoses or complicated cases.
The most important decision, admit or not. This is where many clinicians struggle.
Exactly. Severity assessment determines disposition. The preferred tool is the Pneumonia Severity Index, or PSI. CURB-65 remains useful because it's quick and easy. CURB-65. 1 point each for confusion. BUN greater than 19 milligrams per deciliter. Respiratory rate greater than or equal to 30. Blood pressure less than 90 systolic or less than or equal to 60 diastolic. Age greater than or equal to 65. Interpretation. 0 to 1 points, usually outpatient treatment. 2 points, consider hospitalization. 3 or more, hospital admission likely required, but never let the score replace clinical judgment. A patient with a low CURB-65 who requires oxygen may still need admission.
And who needs ICU level care?
The ATS/IDSA severe CAP criteria are extremely high yield. Major criteria. Either one qualifies. Septic shock requiring vasopressors. Respiratory failure requiring mechanical ventilation. Minor criteria. Examples include respiratory rate greater than or equal to 30, PaO2 over F, IO2 less than or equal to 250, multilobar infiltrates, confusion, BUN greater than or equal to 20, leukopenia, thrombocytopenia, hypothermia, hypotension requiring aggressive fluids. 3 or more minor criteria suggest severe CAP and possible ICU admission.
Do all admitted patients need cultures?
No, routine extensive testing is often low yield. Consider blood cultures when severe CAP, ICU admission, concern for MRSA, concern for Pseudomonas, recent hospitalization, immunocompromised patient. Sputum cultures are most useful in severe disease and when resistant pathogens are suspected. Legionella and pneumococcal urinary antigens may be useful in selected hospitalized patients.
What is the management?
Let's start with the easiest group, healthy adults without significant comorbidities, that is, outpatient CAP treatment in patients without comorbidities. High dose amoxicillin is preferred. Doxycycline is a strong alternative. Macrolide monotherapy should only be used if local pneumococcal resistance is low. Many regions no longer meet this threshold. What counts as a comorbidity? Examples include COPD, asthma, diabetes, CKD, CHF, chronic liver disease, malignancy. For these patients, beta-lactam plus atypical coverage, amoxicillin clavulanate plus azithromycin, amoxicillin clavulanate plus doxycycline. Alternative beta-lactams include cefpodoxim or cefuroxim. Respiratory fluoroquinolone monotherapy. Examples: levofloxacin, moxifloxacin. However, because of adverse effects and antimicrobial stewardship concerns, many clinicians reserve fluoroquinolones for selected situations. For hospitalized patients on the general medical floor, preferred regimen: ceftriaxone plus azithromycin or ampicillin sulbactam plus azithromycin. Alternative: respiratory fluoroquinolone monotherapy. The goal is coverage of both typical and atypical organisms. For ICU patients, standard therapy, beta-lactam plus macrolide. Examples: ceftriaxone plus azithromycin, cefotaxime plus azithromycin. Alternative: beta-lactam plus respiratory fluoroquinolone. Several studies suggest that macrolide-containing regimens may provide outcome benefits in severe CAP.
When should we cover MRSA? Everyone worries about MRSA.
And that's why overtreatment happens. MRSA coverage is indicated only when risk factors exist. Examples: prior MRSA infection, prior MRSA respiratory isolation, recent hospitalization with IV antibiotics, severe necrotizing pneumonia, post-influenza bacterial pneumonia. Add vancomycin or linezolid. Do not routinely add MRSA coverage to every pneumonia patient.
When should we cover Pseudomonas?
Again, only when risk factors exist. Examples: prior Pseudomonas isolation, structural lung disease such as bronchiectasis, recent hospitalization with IV antibiotics. Options include piperacillin tazobactam, cefepime, meropenem, depending on patient factors and local resistance patterns.
What about corticosteroids? This has been controversial.
Very. Current evidence suggests steroids are not routinely indicated for uncomplicated CAP. Potential benefit exists in selected patients with severe CAP, especially those with septic shock. For most ward patients with pneumonia, routine steroid use is not recommended. Never focus only on antibiotics. Supportive management includes oxygen therapy, IV fluids when appropriate, bronchodilators if obstructive disease is present, early mobilization, DVT prophylaxis when hospitalized, management of sepsis if present. Remember, mortality is often related to respiratory failure and sepsis rather than the infection alone. Most patients should show improvement within 48 to 72 hours. Monitor fever curve, oxygen requirements, respiratory rate, heart rate, WBC count, subjective symptom improvement. If a patient is worsening, reconsider incorrect diagnosis, resistant pathogen, empyema, lung abscess, pulmonary embolism, malignancy, heart failure masquerading as pneumonia.
How long should we treat?
This is one of the biggest changes over the years. Long antibiotic courses are usually unnecessary. For most patients, minimum 5 days and continue until afebrile for at least 48 hours. Hemodynamically stable, clinically improving. Longer courses are reserved for MRSA, Pseudomonas, lung abscess, empyema, severe complications. Shorter, targeted therapy improves stewardship and reduces adverse effects.
Let's finish with rapid fire pearls. CAP diagnosis requires symptoms plus a new infiltrate. Streptococcus pneumonia remains the most important bacterial pathogen. Use PSI or CURB-65 to help determine disposition. Ceftriaxone plus azithromycin is the classic inpatient regimen. Do not routinely cover MRSA or Pseudomonas. Severe CAP is defined by major or multiple minor ATS/IDSA criteria. Most patients need only about 5 days of therapy. Clinical stability, not radiographic resolution, determines when treatment can stop. Always reassess if the patient fails to improve within 48 to 72 hours. So, the key takeaway is that CAP management is really about three decisions: confirming the diagnosis, determining the appropriate site of care, and choosing the right antibiotic regimen without overtreating.
Exactly. If you can answer those three questions consistently, you'll manage the vast majority of CAP cases effectively and according to modern evidence based guidelines. Thanks for listening to AudioBoards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the AudioBoards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified board certified healthcare provider for any medical concern.